Hey, good afternoon.
Good afternoon. How are you?
Not too bad. How you doing?
Good. Thanks for having me.
Absolutely. What we'll do is we'll get started around 12:05, if that's okay.
Mhm.
I will introduce you and the talk, and then I will relinquish control to you because I'm sure you want to share your slides, right?
Yes, that'd be perfect.
Okay. Do you see the share button though? Do I need to give you access or?
Nope, it looks good.
All right, excellent. And
Yeah, should I just try to see? Well, I'm
you want
sure
to
it'll
try
be
to
fine.
share?
Yeah, might as well, I guess. No,
There you go.
Oh, it's saying it's disabled participant screen sharing if I click it.
Everything
Yeah, it says
shared.
host disabled participant screen
Uh,
sharing.
okay. See if that worked.
Ah, perfect. Okay.
Okay, great.
Let's see. If I go in presenter, does that look correct?
Yep. Looks good.
Okay, it's not in presenter, it's just in regular, or it's in the correct, not in like notes
Yeah,
form.
I don't see your notes. Don't worry. Yeah.
Okay,
I like the color scheme.
thank you. Yeah, they give us
Yeah.
these templates, which I'm sure
Yeah.
a lot of places do, but yeah, it's nice.
Now, do you live in Palo Alto or where do you live?
I actually live in San Francisco, but yeah, I work in Palo
Oh,
Alto.
cool. How's
So
that commute? Like 30, 40 minutes or more?
yeah, there's a train to Caltrain, so
Oh,
that
nice.
helps.
Nice.
But
Excellent.
should I log off? Which helps a lot, but it's a reasonable commute.
Yeah. I used to go out to the Bay Area a lot. And the one thing that I loved doing was driving down to Carmel by the sea. Um, it was gorgeous out there.
Oh yeah, I mean, there's so much to do. It's great.
Yeah. And of course, you have Napa too, which is pretty awesome.
Yeah, and Tahoe's not too far, so it's a pretty good place.
Yeah. Now I'm trying to look for my slides. Where'd it go? All right, let's find out. Here, all right. I'm going to share my screen. Is that okay?
Mhm.
All right. Let me do that then. All right. If people are logging on, we'll get started in a couple of minutes. We'll let it populate a bit. So, Susan, what do you see right now on my screen?
The main screen you had on before, just the slide.
Oh, you see the Journal Club and the title of the paper,
Yep.
correct? All right, perfect. Thanks. See how we're doing. What folks logged on. we'll give it another minute or two. All right, let's get started, and we'll let people trickle in. Looks like it'll be a little bit of an intimate gathering today. So thank you everyone for joining us on the American Society of Onconephrology Friday Journal Club. Today we have Dr. Ziolkowski. Dr. Ziolkowski is a nephrologist at Stanford University, where she trained as a fellow. She has a NIH F32 grant. And she has a master's in epidemiology and clinical research. Her clinical focus is treating patients with cancer and kidney care, and she actually co-developed the onconephrology program at Stanford. She does research studies on the impact of body composition on EGFR and bone health, and she also implements a lot of her work in machine learning as well, which is sort of the forefront of where nephrology is headed. And today she'll be talking about the recent paper, Predictive Model for Kidney Failure After Nephrectomy for Localized Kidney Cancer, also known as the Kidney Cancer Risk Equation by Harasamy et al. And I should let you know that Dr. Tangri is one of the senior authors on this paper, and you may know Dr. Tangri from his previous kidney failure risk equation that was published in 2011. And I'm sure Dr. Ziolkowski will talk more about that. So Susan, if you'd like to take over, I will relinquish control to you.
Excellent, thank you. Okay, is everything displaying correctly?
Yep, looks great.
Great. Okay. Well, thank you very much for having me. And then this is the title of the journal article that I'll be discussing. This is the overall agenda that we'll go through. So first we'll kind of go through some skits and cases. I actually changed the format to this last night because we had a faculty meeting and two of the statisticians did a little fun skit thing to illustrate a point. I just thought it was such a fun way to do a presentation. So I changed things a little bit to illustrate, potentially why we would be using these risk equations and then potentially some of the limitations. So we'll go through a little bit there at the beginning. And then we'll go through, of course, depth of the journal article. And then finally, just a little bit about AI and maybe how we could improve some predictive models going forward. And there's so many funny memes that we see about AI. I saw actually another one. I couldn't find it again. I wanted to originally put it in here, but it said something like, if you're giving a talk and you're worried that it's going to be boring, add the word AI and all of a sudden everyone will be super engaged because it's the hot topic these days. I don't know if that's exactly true, but I think it's just a fun thing to at least explore because it's everywhere in the media these days. All right, so I'd love to have a guest participant to play the role of Dr. Uriah. And if you don't mind, you would be the actor, so to speak, to read the lines for Dr. Uriah. It's nothing too involved. Anyone is willing and has access to speak, that'd be great.
we'd love some volunteers to help us out. It would if Dr. Ziolkowski and I are talking the whole time, we don't want to bore you guys. Well, it looks like we don't have any volunteers. I can help you out, definitely.
Okay. There's a second one, so if anyone's so inclined.
Perfect.
All right. So if you don't mind being Dr. Uriah, that'd be awesome. I appreciate it.
I'll be happy to.
All right, and then just read the lines.
Dr. Uriah, quick question. Mr. No Data has a nephrectomy scheduled for tomorrow. He is 54 years old and has a creatinine of 1.2. He wants to know if he will likely end up on dialysis soon after his surgery, since his brother was on dialysis. What do you think? Should we do surgery? That's a
oh, sorry, this is me.
Yep.
And Uriah is supposed to be the urologist, and Ranella is supposed to be the nephrologist.
Perfect.
Can't try to come up with some cutesy terms. That's a hard question to ask. I usually need more information. Do they have a history of kidney disease? Any comorbidities? Is the creatinine stable?
Oh, he lives in Modesto and he's never been at Stanford. We only have one lab and he says he's healthy. That's enough info, right? What do you think? Surgery's supposed to be tomorrow, by the way.
And so that's kind of the end of the skit. And I know we kind of sometimes get curbsided by things like this, and we're kind of caught off guard. And the nephrologist then does their due diligence and digs into the chart a little bit more, goes into Care Everywhere, finds, a little bit of info, and does see that this patient actually does have a history of diabetes with retinopathy, a serum creatinine that was 0.8 last year, and it's gradually increased over the past year to 1.2. And does also have some low-grade proteinuria, most recently at 0.7 grams per gram. From what they can gather, there's no other known medical problems. An ultrasound did show some moderate echogenicity of the kidneys. And then a note does mention that the brother is on dialysis at the age of 60 for an unknown cause, but also had diabetes. And then the plan is to have a radical nephrectomy. And so this case just kind of illustrates that a lot of times it's not just as simple as, oh, hey, nephrologist, just here's some numbers. What do you think? It's obviously there's a lot more complexity to our patients than what meets the eye initially. And we're all well aware of that. So obviously I live near Silicon Valley. So we do get a lot of tech people, in our clinic, and, engineers and people who are very data-driven types. So for case 2, I wanted to have someone play the role of same thing, Dr. Uriah, and then I can be Dr. Ranella discussing a new patient who would be Mr. Netflix. So if anyone wants to participate, otherwise, Brad, we can do the same thing.
Yeah, let's see if there's anyone in the audience that would like to role play with us here. It's a quiet group. All right, we can go ahead since I don't want to keep you waiting either. All right, so me as Dr. Uriah, can you do a quick nephrology consult on Mr. Netflix? He's a 45-year-old man with no past medical history and a creatinine of 0.8. He's supposed to have a nephrectomy next week, and we're hoping you could squeeze him into your clinic to go over risk and benefits of nephrectomy. He's been followed diligently by his PCP, and he has no known medical problems. He's an engineer, and he just needs more data before the surgery.
Well, it seems pretty straightforward. If he really has no medical history, do you really need me? The answer seems clear.
Yeah, he just wants more data. This is an urgent nephrology clinic for stuff like this, right?
Oh, I wish there was a calculator for something like this. Okay. And then finally, this is a completely different patient. This is Mr. Complex. So this is a 54-year-old man, no known past medical history, found incidentally to have some renal masses, pretty large size, as you can see, 16 centimeters, 10 centimeters, concerning for RCC. And then the PET also is concerning for lung mets. And then both renal masses were actually biopsied and consistent with RCC. The patient was started on nivolumab and cabozantinib. The left mass remained stable. the right mass did shrink a little bit, and the patient ultimately underwent a left nephrectomy, and the plan is for a right nephrectomy. So certainly this is not just a basic case in terms of risk. And so the creatinine prior to the nephrectomy was 1 with an eGFR of 83. Again, the patient thinks he's just a nice, healthy person. His creatinine does rise following the nephrectomy. He's probably discharged a little bit too early to really know where his creatinine would settle post-nephrectomy, but regardless, clearly you can see a quick rise. Then he had a hospitalization, potentially had a little bit of prerenal AKI, and the creatinine did settle back down. And then now, most recently, his creatinine is 2.04 with an eGFR of 36. So got the kidney removed in a healthy guy. And of course, there was some complication, but it really wasn't anything that extreme, that hospitalization. And here we are with an eGFR of 36, which is pretty devastating considering the patient still will require a partial nephrectomy. And so would this patient likely become dialysis dependent in 5 years after his partial nephrectomy? And, you know, that probably a lot of people do recognize that he's pretty high risk. And the reason why I want to illustrate this case is because he is Mr. Complex. He's not going to be easily captured in a lot of the risk scores that you still need a nephrologist to weigh in and really think about these cases in more detail. It's not so straightforward. So we'll go back to those a little bit to illustrate some points later on, but let's dive into the journal articles. So this is the article, and yes, the senior author is Tingri, which will go into his previous work as well a little bit, which is really been instrumental in nephrology. So in the introduction to the paper, they mention that there is, of course, a risk of renal decline following nephrectomy, whether that be partial or radical. So the figure on the left shows you that the likelihood of a patient maintaining an eGFR of above 45 for 10 years post nephrectomy. So as you can see, the partial nephrectomy people are very likely to maintain their GFR of greater than 45, even 10 years out. The radical nephrectomy people, about 50%, do drop their eGFR to less than 45. They're less likely to maintain an eGFR of greater than 45. And then with a less strict threshold of an eGFR of 60, you can see even the partial nephrectomy people, only about 50% are able to maintain a GFR of greater than 60 in 10 years. And then the radical nephrectomy people, less than 25% can maintain an eGFR of greater than 60 in 20 years. So, or in 10 years. So, you know, we all know that this is a risk. And then, of course, if the patient does become dialysis dependent, that is associated with increased all-cause mortality, cardiovascular events, decreased quality of life, and loss of physical function. So the authors then wanted to find a new risk equation, which would be the KCRE, that could be easily applied at the bedside to predict the risk of incident kidney failure after nephrectomy in individuals with localized kidney cancer. Most of you probably recognize this screen. This is the Tingri kidney failure risk equation that has been around, yes, for about a decade, where it's pretty nice because you can just type in some really simple things. Even if you just have their age, sex, region, GFR, and UACR, you can get a number. And then if you have a little bit more data there on the bottom right, like by adding the albumin, bicarbonate, phosphorus, or corrected calcium level, you get even more information or, you know, more accurate risk. So this would predict the 5-year, the 2-year and the 5-year risk of dialysis dependence. And so this would be the output. So this is actually for the second case. So the first case, so the guy who was a diabetic had a little bit of low-grade proteinuria. I typed in his numbers. And of course, this is not taking into account the nephrectomy, but say if that patient was just in your clinic and you want to see his risk, he's a diabetic and you want to see his risk. So this is what his output would have been, what that risk score would have showed you. And then the other cool thing about the risk score is that if you put your person on a ACE or an ARB or an SGLT2 inhibitor, or you control their blood pressure, you can get a lower risk, and they would show you what the predicted risk then would be by adding those extra parameters, which is really helpful and kind of encouraging for patients to see. So this is the study design for this new risk score that they're calculating. So it was a retrospective cohort study of individuals with non-metastatic kidney cancer diagnoses in Manitoba, Canada. They used the Manitoba Center for Health Policy's Population Health Research Data Repository. The authors mentioned that these are near complete medical records. They included individuals only 18 years and older, had to have non-metastatic cancer that was diagnosed between 2004 and 2016, and they had to be treated with a partial or radical nephrectomy. They had to have one pre and one post serum creatinine. They were excluded if they had a prior kidney transplant, prior dialysis dependence, or both kidneys were removed, of course, at the time of nephrectomy. They were followed until they lost insurance. They had a second nephrectomy. They died. They met the definition of kidney failure, which is the composite outcome, which I'll show you in a second, or they reached the end point of the study duration, which was December 31st of 2017. Then the composite outcome was dialysis dependence, kidney transplantation, or an eGFR of less than 15. The validation cohort was a bigger cohort. It was a registry based Ontario patients. And they similarly had, it sounds like, near complete medical record information on these people, diagnosis of kidney cancer between 2008 and 2018. Also similar, one eGFR pre and post surgery, and then the follow-up was until 2021. The potential predictors that they included in their models were initially similar to their other risk score. They thought it, worked for CKD, it might work in this setting as well. So they looked for predictors including age, sex, eGFR, and then the additional albumin, bicarbonate, calcium, hemoglobin, phosphorus, urine albumin to creatinine ratio, diabetic status, blood pressure status, nephrectomy type, tumor characteristics, and these are what they postulated, a priori to the study. And then their methods, which we'll go into a little bit more in a minute, but the AUCs were calculated, Breyer score, to kind of, it's a method for assessing model accuracy. Then they did calibration plots to see the difference between the observed versus the predicted risk at 5 years. And then they also did the net recalcification improvement statistics. So now using the models, how many people could be potentially reclassified. It's simplifying it a little bit, but whether that be there's improvement in sensitivity or specificity, but basically kind of another way of looking at whether the new model improves upon the previous model. And then this kind of really cool decision curve analysis to see whether or not using the score basically would improve outcomes. So if you use your model, is there going to be a better, worse, or similar strategy to treat all or treat none strategy? So basically, if you just said, no matter what your kidneys are prior to your nephrectomy, we're going to treat you, or vice versa. No matter, even if you have the best kidneys in the world, we're never going to do a nephrectomy. And so basically this decision curve analysis will show you if instead you base your decision based off of their scoring system, does that help? So it's kind of simplifying it, but you'll see it in the figure, which will make it clear. This is their flow diagram. So pretty much what I explained with inclusion and exclusion criteria. So pretty clear. The Manitoba cohort, about 3,000 to start, 1,000 by the end. The Ontario cohort for validation, a lot bigger to start, brings it down to about 12,000 in the end. Here is their table 1. Overall, the characteristics for the development and the validation cohorts are pretty similar. So the ones that they do point out is maybe, if anything, the development cohort does have, let's see, worse outcomes. So they have a little bit more dialysis dependence in the end as compared to the validation. Same thing, a little bit more with a lower EGFR. And I guess, yeah, dialysis. So maybe that's more made up of the lower EGFR than the dialysis or transplant. But yeah, so basically a little bit worse reaching the composite outcome in the development group as compared to the validation group. There's also a little bit more hypertension in the development group, and the follow-up time is a little bit shorter. And more death. If anyone has any comments along the way, feel free to point it out too.
One thing that stands out to me is that the population that was used to develop the Manitoba cohort, develop this equation, it doesn't appear that they're very high risk CKD patients overall. What are your thoughts about that?
Good point. Yeah, definitely. And I think, yeah, it somewhat highlights the limitations too of some of these models, is that, yeah, it's certainly not taking into account. I mean, I think, I mean, there are some people who are reaching, reasonably low EGFR thresholds, but you're right. I mean, certainly the majority have EGFR greater than 60. So yeah, so that's great, a really great point, because can we really extrapolate this as well with some of our sicker patients? Certainly, there are probably some people that are included with lower EGFRs, but not the majority.
There's a comment in the chat by Dr. Suchi Anand, a lot of selection bias. Any thoughts on that?
I was just supporting your comment that, yeah, this is probably the group that the people who don't have really low GFRs, probably people are not pursuing nephrectomies. And that's why we don't see them reflected in this research cohort. So that's all. I was just supporting you.
Excellent point. Thank you.
Do we have a subset analysis of the lower GFR group?
Oh, no. So they do some sensitivity analyses, but that's not the sensitivity analyses they do.
Thanks.
Yeah, no, thank you. And yeah, these are, yeah, great limitations to the work, but still, useful in certain populations for sure. And so now these are the hazard ratios for the different models. So model 1, which is just incorporating age, sex, and EGFR. And then model 2 also adds the nephrectomy type and diabetes status. And then, as you can see, so a lot of these parameters, as expected, lower or higher EGFR is protective. Lower age, it's not quite statistically significant for model 1, but lower age more likely protective. Female sex didn't reach significance. And then they looked at the model fit, like we had mentioned. So the AUC, pretty good AUCs for both models. This net recalcification improvement basically is comparing model 1 versus model 2. And what it's showing is model 2 has better reclassification as compared to model 1. And then the validation cohort, which is the Ontario larger group of 12,000 people, similar AUCs, is the development cohort. Breyer scores are good. And then when they similarly compare model 1 versus model 2, there is improvement in the classification.
Susan, are you able to make a very generic comment on AUC and its application as well for everybody, if that's possible?
Yeah, so certainly the higher the AUC, the area under the curve is suggesting better sensitivity and specificity for your model. And so, yeah, just basically the higher the AUC, the better. And then the Breyer score is then kind of the opposite. You want a really low Breyer score to see how well your model fits the outcome. This other one, this Ikeki information criterion, I tried to read more about that. I'm not as familiar with this one, but my understanding is that lower is better for this, and that it's also similar. It's a way that the model fits the data it was generated from. So it can compare, compare different possible models and determine which one is the best fit. So a lower number is better. So I think all of this is just supporting model 2 is better than model 1. The next analyses they did took a subgroup. So this actually only included 377 patients for these. So the group that has a urine albumin to creatinine ratio, so same as model 2 from the previous slide, but now they just got rid of, anyone who didn't have a UACR, so that they could equally compare it to the new model 3 that takes into account same thing as the previous, but also UACR now. And then these models now are showing that there is similar improvement with so the net reclassification comparing model 3 versus model 2, so better reclassification, and then same thing in the validation cohort. So basically their conclusion with all of this is that kind of similar to the Tangri risk score that we use for CKD, if you do have all these parameters, you're going to get the most accurate risk assessment. But the other, models certainly had pretty good numbers as well. But then they did these figures to show us the recalibration. So I apologize if this is, it's not too small, but they put the patients into different deciles of risk. And then within each decile of risk, what was the predicted risk as compared to the estimated risk. So the development cohort, only 377, including the ones that had the UACR. And then they took the validation cohort, which was, so anyone in the validation cohort who had all of the parameters, which is 4,000 people. And then compared, predicted versus estimated risk. And then the final was that basically they took the validation cohort, but they recalibrated with the coefficients from the development cohort. They used the coefficients from the development cohort, but adjusted with the baseline hazard ratio from the validation cohort. So basically they used the development cohorts to predict their risk, but they did it in this validation cohort. So overall, they're basically showing that the predicted versus the estimated risks for every decile is fairly equal if you use the coefficients from the development cohort. So it's kind of showing that it's a nice model overall. The sensitivity analyses that they did were looking at they kind of had more strict criteria for what met the composite outcome. So as I mentioned before, the composite outcome was dialysis, transplant, or EGFR less than 15. But what they did instead was that they included only individuals who had an EGFR of less than 15 on 2 occasions, found similar area under the curve, which is 0.86. Then they also did fine and gray analyses where they accounted for the competing risk of death and found similar outcomes or similar AUCs when death was included as a competing risk. So basically just kind of using more strictness, I suppose, to their methods, and similar findings were seen. This is the decision curves. I think this is kind of a cool figure. So what this is showing is on the x-axis here. So what was the threshold probability of risk? So basically, if you did a patient's risk score and you got 50% risk, as compared to 0.01% risk, that's what this is showing on the X here. And then the net benefit of using the treat all versus the treat none approach and the probability of kidney failure at 5 years. So basically, the red line is basically showing that no matter what risk score you get, even if the patient has a super, super low risk, you do not do a nephrectomy. If they have a super high risk, you're similarly not doing a nephrectomy. So you're not treating anyone. So clearly there's no net benefit here. But then if you just treat everyone, okay, when you treat everyone and they have low risk, that overall provides some net benefit. But once you reach around 20% risk, then the risk of treating everyone starts leading to some potential harm. And so that's why you start seeing that there's less net benefit when you just start treating everyone when the threshold is 20 or more. But then in this line here, if you use your kidney failure risk equation instead, and you base your decisions based off of that, that you're going to have basically better net benefit throughout. So if, for example, at a 50% risk score, you would be deciding to treat people with, not treating the people with 50% or more, or treating people, or yes, doing the nephrectomy in people who have less than 50% risk, and then not treating the people with more than 50% risk. Overall, that's a better strategy than just treating everyone no matter what, or not treating anyone at all. So, what this does not take into account is, of course, what we do in clinical practice. No one treats everyone, and no one does not treat anyone. So it's not taking into account what the clinician's already doing, but it does show that if the clinician just blindly followed this risk score, that they would still see overall net benefit, I guess, than just treating all or treating none. So it kind of just supports the findings of the study. So their discussion mentions that, so in the development cohort, 10% of individuals reached kidney failure after nephrectomy. The final model resulted in a 5-year area under the curve of 0.85 in the development cohort and 0.86 in the validation cohort. So really good numbers. The limitations were that you probably need to look into this more in different types of cohorts. Of course, like I said, they have a validation cohort, but they're both Canadian populations. So can we really extrapolate this to other groups? And then the externally validated model can be easily applied in clinical practice to inform preoperative discussions about kidney failure risk in patients facing surgical options for localized kidney cancer. And that's their whole point, is that similar to their other model, it's easy to type in. You can do it in a clinic visit in 2 seconds, or we could tell a urologist to do it. That's what's nice about it. It's not supposed to be an overly complicated model, and that's what makes it useful. And then, as everyone else pointed out, But, you know, these are non-metastatic cases. Like we said, that the EGFR is pretty good in the cohorts as a whole to start. So it's not really taking into account the breadth of physician or patient characteristics that we see. And then just a little bit to talk about how we could maybe improve upon some of these methods, but I don't know if anyone has any other points about the journal article that they wanted to bring up. I'll bring it back in a minute, but I think with these risk scores, like these papers are, you know, I think it's a good paper, and they you know, did a really good job overall, but certainly we have to recognize limitations to these calculators. You know, we can do more than just.
Sorry to interrupt, Susan, and everyone else. I just wanted to make the point that there's a 10% incidence of kidney failure in the follow-up time that you mentioned. So this argued for continued nephrology care after nephrectomy.
Good point. Yeah.
Susan, before you get into the AI piece of this, one comment that I had is I'm not even sure that many of these patients would be routed to me with that sort of GFR. It's always the patients that have that EGFR of 30 or 40, and you're doing a MAG split scan and pulling your hair out. That's the complex ones, as you alluded to in your case earlier. Any comments on that?
100%, you're right. Like, and say, for example, in the first case I mentioned, the urologist comes to us and says, the creatinine's 1.2, what's their risk? And that's all. Like, so if we typed in with the little information that the urologist gave us, the risk score actually might not be that bad. But then when we take into account, oh, their creatinine was 0.8 last year, they have diabetic retinopathy, all these other things that is not captured in these models. Diabetes status, of course, is, and proteinuria, but we don't always have UACR. And of course, this model, I don't think they actually made the nice website like they did for their previous risk score yet. I'm assuming it's going to be coming. But so, you know, but I'm assuming they're going to have something similar to the previous Tangri risk score where, let me see if I can go back, where like you have the option of typing in UACR. So, so say in the first case I mentioned, if we just took an age, sex, and his GFR probably wasn't too bad. Oh, I guess, sorry, actually you did need UACR right off the bat for this one, but I don't know in this new one if UACR will always be needed for the score, because as I show with the models, like UACR wasn't in every model that they developed. It wasn't until the model 2 or model 3 that they accounted for UACR. So yeah, there's a lot that's lost in the simplification of this. But then the beauty in the simplification of this is that the really low risk patients at least can get some reassurance. But you hope that just, the urologist is not missing something glaringly obvious. So. All right, so how can we improve upon this? So, I mean, the more that everyone's talking about AI, I mean, I think the simplified way to think about AI is that it's just another tool. Like we use logistic regression, we use linear regression. AI is just another way. It's just another tool, basically. And so it's been around, you know, for a long time. And I'm not going to go into all the nuts and bolts of AI because that's way too involved, but just to really, really overly simplify this, the beauty of it is that you could take a lot of really interesting patient data from the EMR, whether that be labs, you could do even stuff with imaging, all sorts of data, real-time vitals, and then it can all be put into a training set. And then that would be your input in the little white circles here, that's your input. And then in a model where you have a supervised output, you would have an output. So for supervised training, for example, in this example, you would have the outcome of end-stage kidney disease, for example. So you put in all your inputs, your outputs, end-stage kidney disease, and then the model figures it all out. And the nice thing is that it's not confined to the linear relationships that we need to see with current statistical methods and things like that. It's allowing for all these really complex relationships to be processed. And so that's why it's just another tool to just get a different prediction. So then this new model would be able to tell us what the risk prediction would be by synthesizing all of this data and not just small bits and pieces. So that's what's kind of cool about AI in risk prediction, at least. And again, I know I'm oversimplifying this, but the important thing about all this is that we don't just want to take everything that the clinician is doing and giving you a risk, because I think clinicians, you know, when we looked at the cases I mentioned before, one was a little trickier. He had diabetes, proteinuria. The other one was pretty straightforward. So most clinicians could look at that in 2 minutes and probably get a sense of what their risk is, right? And that's what you don't want. You don't want just a model that's just going to tell the clinician what they already know. And that's, I guess, maybe reaffirming, maybe it gives some patients some comfort, but it's not going to be as exciting and helpful, I guess, in the long run. But what would be helpful, though, is say if, for example, Mr. No Data, the limitation would be that if, say, Mr. No Data seems a little higher risk, he has diabetes, so then the clinician orders extra labs, sends him to a nephrologist, then the model would tell you, oh, they're high risk, but the model's just telling you what the clinician did. Whereas Mr. Netflix would be classified as low risk because the clinician didn't do anything. So the model's just kind of following what the clinician did and tells you high or low risk based off of that. So that's what you kind of want to avoid, is that the machine's just, quote, looking over the shoulders of clinicians. I thought that was kind of a cutesy way of phrasing this. That's what you don't want. But of course, there should be ways that AI could improve our risk assessment, right? So you could potentially use AI to take non-clinician initiated data like raw imaging results, real-time vitals, lab outcomes, or data that's difficult to interpret, or just, again, in a quick clinic visit or a quick assessment by your urologist. They're not going to look through every vital and everything. That's just too much. So it can synthesize that. So what could potentially happen would be, say, for example, the model would then pick up on subtle findings about Mr. Netflix. Mr. Netflix seems super low risk, but the model notices some little things on their ultrasound. Maybe there is actually some echogenicity there, and then spits out to the urologist, this patient's actually higher risk. And then the clinician will think for a second, oh, wait, he seems super straightforward. What is this model picking up that I'm not seeing? And then the clinician could investigate further and maybe actually determine there's something else that they're missing. So then an example of this would be that the model predicts low risk of ESKD in 5 years. The patient undergoes surgery. The creatinine, though, was in fact actually on the rise. So the patient was harmed by doing the surgery and now is on dialysis. And so that's what, say, a simple model like the Tingri models don't really capture the rate of rise of creatinine prior to nephrectomy. They're not going to see that. But maybe a better model would allow to synthesize more data and detect that creatinine was on the rise, some other parameters that are more involved. And then the model predicts higher risk, patient does not undergo surgery and does not end up on dialysis. Simplifying this a ton, but you know. And then also the other important thing is that we need to have models that update as quality of care improves. So same thing, model predicts high risk of ESKD. The patient does not undergo surgery. Surgical techniques improve, diabetic care improves. Model still has same prediction of high risk, 10 years after the model development. But now, if we were able to update our models, it would predict high risk of ESKD in 5 years. The patient does not undergo surgery, but then the surgical techniques improve, diabetic care improves. So the newer model actually would be based on this newer data. And then it would actually show you that the patient is low to moderate risk for surgery. So, and it's not like we would be doing the same model in the same patient every year. That's not the point. But say an identical patient seen 10 years ago is not treated as the identical patient seen in current times, that these models would be improved upon. But this is tricky because actually Suchi sent me this article that showed that the implications of use of artificial intelligence in healthcare settings. So they looked at these models and how are they able to update. And so this is just a simulation study, so it wasn't in real time, but it was at Mount Sinai and at Beth Israel, and they looked at critical care admissions and basically showed that a mortality model that was deployed once and retained lost specificity the second time they deployed the model. And the point is that when these models are released, clinicians start acting differently in response to the models. And then the model starts updating with those new outcomes. And then in turn, at least in scenario one, the specificity was altered. So the patients were considered to be higher risk than they actually were. And then they did other scenarios where a mortality model was deployed after an AKI model. The mortality model didn't hold up as well because clinicians were changing practice patterns in response to the AKI model. And then finally, the models for AKI and mortality prediction were released at the same time, and both models kind of fell apart. So clearly, this is a very, very, very new paper this month. A lot of this is not figured out on how to do all this. And we all know the implications in healthcare are a lot more involved than updating a Netflix algorithm, for example. You know, God forbid you see horror movies because you clicked on a horror movie once, you know, and you see it for the rest of the week. That's not going to really hurt someone. But if these models are getting worse over time, that's got huge implications. And so that's what's so important about AI is that we really need to be, it's almost like a lot more ethical considerations with AI than there is with traditional, you know, statistical methods. We really got to be careful. What are these models doing? And I think I just have 2 more slides. So the opportunities for model improvement with AI, so integrate complex medical data such as imaging results, genetic markers, dense clinical notes, and synthesize the risk score for a clinician to double check their assessment and provide more time for counseling. So this book is a pretty cool book. His whole point is that AI shouldn't be taking away the patient experience with the clinician. If anything, hopefully it will improve as these medical charts are just getting so dense. Clinicians can barely look through oncology patients' breadth of records before a visit. But if AI can somehow improve this system for us, maybe then we'll have a bit more time to actually chat with the patient and hear what they had to say. And, you know, we all recognize the importance of that. And so that's ultimately the goal, at least in this author's thoughts. And then, yes, we could update the model to new standards of care or to adapt to a particular new environment, different race, ethnicity, social economic groups. So, you know, is this Canada risk score relevant in Brazil? You know, these AI models could be a little more updated quicker and allow for risk assessment in more complicated medical scenarios, like we said, lower EGFRs, metastatic cases, things like that. So in conclusion, the Tangri model can be used for decision support and patient counseling, like in patient case 1, Mr. No Data, diabetic. It's sort of unclear, is he going to do well or not? It can maybe help with decision support for basically the patient and the clinician. May aid in appropriate use of nephrology consults. So Mr. Netflix seemed really, really healthy. So do we really need to take up a nephrology spot for something like that? But, you know, you want the patient to feel good about going into a surgery. So sometimes these extra tools are nice, you know, to have. And then the potential for models to become relevant as healthcare advances is an important consideration. And then machine learning is an opportunity to enhance clinicians' ability to synthesize complex data and provide efficient methods to improve risk prediction. So the more complicated patients maybe could be assessed. And that's all I have. So happy to hear everyone's thoughts on things, or if anyone has questions.
Thank you so much, Susan. The chat is empty. Does anybody have any questions? You can unmute yourself. We covered a lot of ground.
Yeah, I think this is a much needed topic. It's definitely fertile ground for research, and we get these consults all the time. And so I think I think I would like more tools, not less. So I'll continue to follow your work very closely.
I want to throw in something also, if I can. Thank you, first of all, for giving this talk. And thank you for inviting those of us who are in private practice. I wear two hats. One is onconephrology. So I think that was Bira who just said something before. I get this question all the time in the office, twice yesterday, with patients who had nephrectomies or are going for nephrectomies. But my other hat is, as a general nephrologist, I get the question from the transplant world also in terms of donors. And while these are patients that we're seeing here in this paper with diabetes, with hypertension, or certainly a certain amount of it, and we don't take those as donors, I wonder if we can use this data to open up the donor pool, the living donor pool, for people who may, instead, not a 40-year-old, but maybe a 60-year-old or 65-year-old who may have some amount of diabetes, but now we know their risk long-term. So I wonder if we can use this in other areas.
Yeah, that's such a cool thought. You're 100% right. You mean the Tangri risk score, just to provide some reassurance for people, yeah, with lower EGFRs. But yeah, if you get a kidney removed, what's likely going to happen?
Well, maybe they have normal,
totally valid,
maybe they have normal,
sure.
Maybe they have normal GFR, but they have diabetes and hypertension in the background, but they're 65 years old, want to donate to their child. What's their risk? Is that a risk that we would be willing to take as donor nephrologists or as a transplant center? Is that a risk we're willing to take? Or is that a risk that the donor would be willing to take?
Yeah, and I mean, I think decision support is just such an important field for, you know, patient outcome or patient, you know, I mean, yeah, like you said, nephrectomy, it's not for a donor is not neat. I mean, it's an elective process. So to make any patient feel more comfortable about their choice, totally, if more people are willing to be donors because of that, amazing. And or at least allow them to feel like they're making a more informed decision and giving clinicians more tools to help with the counseling. Yeah, so I'm curious that when I hope they do publish the nice website like they did, you know, for the other one soon. I don't know how long. I'm sure it's not an easy task, but it's just such a cool website, that, you know, the existing one. So it's just, I think a lot of patients like that type of thing.
This is a super random thought, but one of the things that was noted on this paper was that people were followed up till they lost insurance. And I just assumed that everybody in Canada has insurance. So I thought that was a little strange.
I agree. I actually thought about that too, but I didn't look into it, to be honest. But I agree. I was like, how did that happen? But maybe they're, I don't know. I'm not sure.
Well, Susan, I thank you so much for, you know, this is a very complex paper and the mathematics behind it. So we appreciate your expertise and the work that you do at Stanford. Thank you also giving us the bonus on the AI piece. That's a little primer before we get to Kidney Week. I know there's gonna be a lot of AI talk during Kidney Week. So thank you so much for your time. Thank you for everyone for joining. I hope you guys took some valuable educational pearls away from this. Thank you again.